So we're going to close at 3, but we now have time, a fair amount of time for your questions and comments. And again, focus as much as you can on the question about the evidentiary basis, the gaps, extension in terms of data collection, and in terms of research agenda. And you may direct it to any individual or to as many of the panel as you would like. Yes, start here.
This was excellent. On the other hand, it was overwhelming, right? There's so many issues you guys identified for research. So while we're sitting here, I got an email inviting me to come up to Albany to testify on a bill in New York, right? And so my question is, right, New York, and there's going to be, of course, hearings coming up in Massachusetts, Hawaii, New Jersey, right? The New York senator asks me, or let's say they ask you, like Dr. Wenger, Dr. Magnus. I happened to catch the last 20 minutes of that National Academies thing, and you guys identified like 97 big unanswered questions. What's the upshot of that? Should the state of New York wait until some or all of those questions are answered? I mean, in other words, how grave are the unanswered questions that you guys have identified? And I guess that's really for anybody. Thank you.
Thanks, Thaddeus. I'll get back at you later. I mean, we thought at least that our task was to really focus on the issue of future directions for research, not focusing on what's already been known, a lot of which was to also discussed among our panels. So what I would say in response to that is to talk about what we do know. So what we do know is reassuring in some ways. So some of the at least early concerns prior to introduction of PAD obviously are things that at least to date have not been borne out. So we could always point to the body of knowledge and what we have. The fact that there's a lot that we don't know is concerning. And so as I say, I'd say the knowledge about what the ancillary impacts are on patient care, there's a lot of speculation about that, but we don't really know what that is. And if that's really important to people in making this decision, then I think we have to just be honest that we don't really know very much about what some of those things are. In the end, when we figure out ways of digging into this, either it's going to turn out that the experience in the Netherlands is borne out and that a 25-to-1 ratio roughly of people who bring up this sort of thing to everyone who actually winds up leading to a prescription. If it turns out it has tremendous benefits to all 25 of those, so there's a large multiplier effect from the very tiny number of people who are doing it to make it a significant increase and improvement in quality of end-of-life care, and that there's no other way of achieving those things, then I think a lot of people like me who come to this from a relatively neutral perspective might be flipped over in that direction. If on the other hand we find that some of the concerns that people have and ancillary things are actually very, very negative, people like me are going to flip. And if it turns out it's only relevant to this tiny number of people who are getting it, and that's really it, and that's all we're going to have in the U.S. is Oregon and a fraction of 1%, then to be honest, this is not a very important topic.
Any other response? Okay, before I get Scott and then Dan, Anita Silvers, who's online, has a discussion question. Can you connect her?
I am connected.
Great.
Can you hear me?
Yes, I can hear you. We can hear you.
Okay. All right. First of all, I'd like to congratulate the organizers in attempting to have a workshop in which empirical data were the focus rather than advocacy. And I think this workshop has showed how hard it is on this topic to achieve that. But I think you've done a great job of trying to achieve it. I do want to comment on the matter of getting data about individuals with disabilities. It isn't an easy thing to do because it is unclear who is disabled and who isn't. I think I said in my talk that there are at least 5 federal definitions of disability. I think this is a very worthwhile thing to do. But nobody should start by thinking, just ask whether people are disabled and they'll tell you. So that's a comment about about data acquisition. And I do have one other suggestion for a study that I've not seen anywhere. And that is a study of hospitals that have different policies but are close to each other. In California, I know that we have hospitals in the same city that have very different policies about how they're going to handle this. And I think it would be worthwhile to do studies on their experiences to see whether, given more or less the same populations, or at least the same geographical site, how each of their policies works. Thanks.
Thank you. Who would like to respond?
That's a really good idea. And in fact, it's outcome data like that that we have none of. I have to agree with David. We actually know a lot. We know a lot about patients who receive prescriptions and what they do with them. Oregon has taught us a whole lot over a long period of time, but we know nothing about outcomes.
Well, I know a couple of hospitals in San Francisco that have quite different policies, and it'd be fascinating to see what the difference in outcomes is.
Any other response? Thank you, Anita. Scott.
Thanks. So first, a confession. So I am a unapologetic, unabashed data geek. There's hardly a problem for which I don't think the answer is more data. But I'm finding myself struggling with this call for more data in this space for the following reason. There's not been a single data point presented today that speaks to this question of whether PAD is a good thing. And that's typically the standard that we would use for something in the healthcare space. Is drug A good on balance? Is palliative care good on balance? This resonates with the last question. We've heard absolutely nothing about that question. And I think I was very heartened to hear Neil's suggestion for a case control study, which I think could get us a decent amount of the way there. I actually think we could do better than that. It's perhaps no coincidence that the state of Oregon has taught us most of what we know about the value of Medicaid, right? Oregon had the wisdom, knowingly or not at the time, to effectively randomize access to expanded access to Medicaid. And almost everything we know about whether Medicaid is a good thing comes from that. It's not totally inconceivable that we could do a similar thing here, but it requires a couple leaps of faith. And I would just raise the question for the group's consideration as to, if we're not going to make the social commitment to have that standard of data about PAD, and arguably we ought not, then would it be better for us to stop saying that this is a data-driven entity entirely, and stop even calling for data and just agree that this is something that's on that kind of uncomfortable saddle between the political and the metaphysical?
Okay.
I empathize with your question. But one thing that I've become convinced, so over the last 2 days, what's clear to me is that no data will convince the people who are firmly opposed to endorse, nor will it convince the people who are firmly advocates for to oppose. Those are views that, from what I can tell so far, are held deeply from people's personal experiences and their faiths and their outlooks and all sorts of other things. So data is not going to change any of that. And I think if we hope that it's going to, then we're in error. What I think data can do is tell us how to manage a situation, assuming it's going to be legal, most safely, most efficaciously, most effectively, and with the best variable other kinds of outcomes, so that we can make choices on how we do things in there. At a very real and kind of granular level, there's been this much talk about the drugs that are used. That's certainly something we'd want to know about, right? Is which drugs are going to be more effective than others in making this happen without bad side effects. So I don't want to make this a data-free zone. I just think we need to be honest about what data can and cannot do and what the goals of that data are.
Any other response from panelists?
I don't think we disagree with that. I mean, I think it would be great in the ideal world if we could do a randomized trial in some way or a cluster randomized trial, but I just think that's unrealistic. But I think there are lots of other parts of medicine where, I mean, when it comes to the level of introduction of policies, there's lots of things that we do all the time. There's variation in code status ontologies, a project that we're both working on. There's lots of things that we do that would be very hard to imagine doing anything other than a case control trial to look at best. And there may be other kinds of data. So the data we get may not be the optimal gold standard data we'd want to really see what the outcomes of those things are, but I think trying to do work to try and answer the questions and get as much data as we can to find what best practices are and what works well is really important. And then I think about the ancillary things, there's just a lot of claims being made, and I think trying to do what we can to explore some of those things is just important for contextualizing this, and for the large number of us who don't have really very firmly fixed positions and who kind of sway back and forth with the data, that might be very important for us in terms of our views about this.
Let me briefly add that we digested Linda's body of research before we implemented how we were going to use this new law at UCLA. So I think the data serve a very important purpose, but I would agree with David that there certainly are those at the ends that will never be convinced and no data are going to affect. But I bet that there's a large body of us in the middle where these data would be very important.
Dan?
Yeah, my question sort of follows on Scott's, and I'll thank Neil for challenging us to the question of the relationship between ethics and data. We can maybe have a discussion, the three of us even, afterwards about how we would actually try to implement that. But here's, again, the concern that I raised at the beginning of the program yesterday morning, which is, as was stated in some ways, once you sort of get into the health services research mode about these questions, you've already in some ways sublimated the question of whether it's good or not, right? It's either neutral or it's good. And there is a way to address those questions for open-minded people. It's not just that people are fixed in their ideas. We can argue with each other in an ethical framework about those questions. But once you get into the framework of health services research, then I think what James was saying comes true. Then the things that make things good or bad are defined as efficiency, efficacy, safety, access, implementation, all the kinds of things we've been hearing about, which are important, right? But they sublimate the ethical questions, which are put to the side, and they also sublimate the sort of big social kinds of questions that Richard and Joanne raised. So it's a word of caution about that, and if there are ways to get out of that bind in terms of what data can do for us, I'd be thrilled to hear them. But I think that we have to recognize that problem with the health services research model. So.
Okay, any other response? Okay.
I'm Bonnie Reagan from Portland, Oregon, and I was on the task force to improve the care of terminally ill Oregonians with Linda and Katrina, and I wanted to make 2 points. One is we've talked about the psychiatric assessment for depression or other mood disorders that impair judgment, and it's not as if there's a psychiatric evaluation or nothing. Family doctors or internists see patients first, and all of us have had training in psychiatry, not to the extent that psychiatrists have by any means, but some, so that we can detect questions about depression and other mood disorders. And hospice also evaluates patients, and they have psychosocial evaluations. So there is some evaluation. It's not like there's nothing. The second point is that when I gave a talk on the Death with Dignity Act in Milwaukee, Oregon, many years ago, an oncologist from Wisconsin came up to me and he said, "I wish you guys had not passed that law." And I said, "Why?" And he said, "Because we already know how to take care of our patients. We do what you do, but we do it quietly and secretly." And I want to say that context is everything, and that Oregon bringing it up out of the darkness and into the light so that people can discuss it, as we are doing here, is critically important. And I thank you for the forum to do that.
Any response? Okay, John Kelly.
My name is John Kelly. I'm from Not Dead Yet. I want to counter the general impression being given that disabled people are somehow a distinct separate group from the people who are using the program. At least 90% plus of the people using the program are doing so because of loss of autonomy, loss of abilities, and bodily shame over needing help from other people. If the program is going to run with state and institutional support for aspects of disability that those of us live with all the time, and there's talk about extending assisted suicide to my population, we have to ask, are we equal citizens? Do we receive equal suicide prevention? The only answer to this question that would be at all fair is to open up assisted suicide to the entire population for whatever people want, but to focus on people who have incontinence or depend on others or have lost ability is a form of the most deadly ableism and partakes in a culture-wide fear and hatred of people with disabilities, and it's led by a distinct social group for whom status gets destroyed with disability, and we're not hearing from people where status comes from our social roles as grandparents and grandmothers and esteemed members of families and community. Thank you.
Okay. Any response? Richard, I saw you nodding.
I would only, yeah, I'd just say it's part of, not staying on. Okay. It's, yeah, it's part of the broader concern that I raised about how we think about expansion, or should we even think about expansion of access to this without knowing, right, whether it's a good, having really settled is a good thing, a bad thing, and in the absence of having, you know, really voices from a very diverse group of stakeholders in this. And there are stakeholders from all stripes here, not just so-called disabled versus abled, but you know, people in different socioeconomic groups, et cetera, as we discussed. So, I mean, one of the questions I would want to ask if I were the senator is, how are we to know that these protections that have been put in place for this practice will remain in a scale-up of this practice, particularly when there are statements in the literature about we really want to, you know, expand the categories of who is eligible, and that, oh, what about that data from the Netherlands, which some people believe, some others don't, that there are people who apparently don't voluntarily consent to this. So there are all these questions, right? And so how confident are we that in this kind of very incomplete state, and if there's a call for no more collection of data, how confident are we that this could in any way be a practice that could be promulgated in the absence of more data?
Okay. Thanks. Tony?
Tony Buck. I would like to build on the discussion that we've been having about the limitations of data and where the discussion is. And I wondered, as another issue for the agenda, not to put more things on our plate, but I can't help but think that one of the things this workshop has shown is the complicatedness of bringing together a sector of public viewpoints and stakeholders and professional viewpoints and stakeholders. And in some sense, I am wondering, what do we know about how to effectively create a process of public and professional engagement around something? James mentioned that the the issue of abortion as a model in some ways. And I have to admit, it's a great analogy, but it made me cringe a little bit because I don't think of that very polarized topic as creating a public dialogue that has resulted in a situation that is really the best for the public, even if you look at all the different viewpoints involved. And I wonder if we could turn our use of the scientific process to figuring out how to create and monitor and watch a process of engagement that would bring us in a different way to some of the issues that are here. I have been watching, for example, the Canadian work about end-of-life care, the national process that is going on, with great interest. It's enormously thoughtful, and I feel like that kind of big picture view that included this issue about, from end-of-life care in a broad sense to this issue as, one particular kind of, high-risk, low-frequency example. I feel like that would be so enormously beneficial for this particular dialogue. So. It's a suggestion. Anyway.
Any response? I'm sorry. Any response, Tony? Nancy?
Jennifer Gibson and I were having a similar conversation about this because, of course, the societies that we're talking about are all demographically aging societies and have many, many points of continuity in terms of what people need. Joanne Lynn has talked about OECD nations and common needs. This certainly isn't the issue. If you thought about what people, you would probably put housing at the top of the list or food or something like that. But I think that is absolutely right, that thinking about how to have the public conversation, rather than imagining this is only about medical ethics or healthcare ethics, it's about how people think about themselves as aging people, as people with chronic illness, as people in aging societies. I think that I don't have the strategy for it yet, but I've also been watching the Canadian process and the fact that they are very proactive with what they put on their public websites, and they have 3 different expert panels that are going on their version of the national academies, the CCA, and that was mentioned that there will be a report later this year. But I think some transnational discussion might be very interesting.
Right. And could the National Academy help foster something like that for this issue around for us? Thank you.
Yeah.
I'll just quickly add that, Tony, what you were talking about at a national level is, I think, what happened in every health system and many institutions when this law got passed. I believe it happened in Washington, and I saw it happen across systems in the United States. At my institution, we had 50 people in the room that had never gotten into a room together, amazingly diverse, from every kind of clinician down to a disabled individual, down to nurses and doctors, and we basically tore at each other for 2.5 hours at a time every single week until we came up with a policy. Was it the best possible policy? Maybe, maybe not. But it's that kind of thing that I think that you're calling for at a much broader level.
Sorry, I just have to acknowledge that Barbara Koenig's work on, and some others on, using deliberative democracy as an approach to thinking about these issues. And so I think that's, in a way, as Neil said, we did the same thing. We had 20 town hall meetings, hundreds and hundreds of physicians, nurses, social workers, clerks. Learned a lot from that. One thing that we haven't talked about, and I don't think anybody's ever mentioned, but one of the things that we learned at one of those town hall meetings was somebody who's not a healthcare provider, but who answers the phones when people call the clinic. And they raised this problem that, when somebody brings up suicide, we're supposed to send them down this pathway of to a mental health professional, and they didn't know how to deal with it. And it was only because we did that we realized we have to really look at our scripts and retrain all the people who are making these phone calls. We wound up sharing that with some other healthcare systems in California that they need to do something similar. But it's really only because of that process of engagement broadly that we're able to identify that. But deliberative democracy would give you a very an opportunity for some sort of systematic, controlled ways of doing, and the kind of work Barbara's done, being able to sort of apply that in this realm. And other folks at Stanford who's developed the technique, you can do a lot of that online and use technologies to make it actually very, very broadly participatory.
So I totally agree. It would be wonderful to see that sort of discourse be able to happen. Unfortunately, I do worry that this is simply a microcosm of polarization in our society overall. I mean, we have this kind of polarization on everything. I do think that if it's going to be successful, it's going to be successful locally, whether that's regionally, state, or even more likely in, for example, one hospital or one community. That's the way you can really have a conversation. And I do have to say, I made this comment to somebody else, and I again, sort of hate to go there, but you mentioned the abortion thing again. What this feels like to me right now is abortion if Roe v. Wade had never been passed. And so what would happen is you would have state by state changes, and you would have what essentially is happening right now, which is that let's just name it, the blue states are passing these laws. This is not about to happen in Mississippi anytime soon. And I don't know what will happen over a much longer period of time. Now, obviously, and then what it does maybe allow is in those states that pass it to be able to have the kind of conversations that we're talking about, and that's a good thing. I don't know if we're going to be able to have those conversations in the other states. Now, of course, if you don't want it to pass, then that's a good thing because it's simply kept out. And to the view of people who want it, then they view that's not being allowed to people in those states. So it's all complicated. But I think that's kind of that is how it is playing out right now. And it's, I think, an interesting experiment. And then how can we try to do some of this deliberation in the local space?
So we have 4 people in line, and that will take us just past 3. So if I could ask the 4 people in line to be very brief in questions and panelists to be very brief in responses. Yes?
So to be succinct, I'm John Fry. I'm a big fan of engaged neutrality, and I love the people here who are speaking to both sides of the issue. My sympathies are with those telling the narratives on both sides, but especially in the middle. And I view my role as an ethicist as someone getting those cases to the persons most in need of them, which is in some cases the patients, but is often enough the physicians. How can we get these qualitative data, these not the data, but the narratives, narrative-based, case-based learning to physicians in ways that we can help them in their own practice when they're trying to help their patients?
Any response? Okay.
Hi. Again, my name is Ron Motley. I'll be brief as I can. I want to just comment briefly on some observations, reflections, and so forth that have come to me and that I think may be beneficial for us as healthcare providers, doctors, and so forth. I will be as brief as I can. Not as an aside, but as a central point I have thought about throughout this entire conference is my time in the Marine Corps during the Vietnam War. I was in for 6 years, went through Parris Island and so forth, 1966 to 72. Obviously, we had these basic codes that drove our God, country, duty, Corps, honor, and so forth, that drove the Marine Corps mantra of action. One of the central thematic directives was, obviously we learned how to kill, and I'm not trying to be explicit or really negative here. I'm telling you the reality of how I see this, is that we were taught how to kill people. And I think of and one of the things that we were taught was to reduce the threat or eliminate the threat. And one of the things that I see for those who have come to us as a collective body, the sick, the dying, the suffering, is they've come to us to say, how do I reduce the threat of my fear of suffering, my sickness and illness? How do I alleviate this pain? How do I reduce that threat? Doctor, help me. Or how do I possibly eliminate it when it becomes too overbearing and unbearable? I hope these are useful terminologies or ways to compare, contrast what I'm trying to communicate to you. So they're coming to you with very, very real needs that are terribly compelling, as we've heard. On the one hand, They are very real, and they're going to die whether we help them or not. As doctors, physicians, we follow a particular code of ethics and morals, or maybe we're completely amoral. For me, as a moral caregiver, I follow things that I believe are right and so forth. But at the same time, I think the nature of the needs these people present calls us to, as doctors and nurses and practitioners of medicine and healing, to bring about ways, how do we reduce the threat to our profession of practicing medicine, of administering care, of bringing healing to these people, administer the threat to those principles in the process of caring. How do we eliminate for ourselves, other than opting ourselves out, ways of engaging these people that are acceptable morally, ethically, and so forth? Are they simply continuations of long-term care and funding that? Or are they being practitioners of PAD? I don't know. And I relate all this.
Was that enough to get a response?
That's enough. Just any kind of observation.
I think what Linda taught us and what we have learned big time is that these patients that are making these requests do not want to die. And in fact, I think what we heard from many of the systems that were presented here today and yesterday is that the systems that have been developed are there to attempt to allow people to have the best possible end of life. And to have the best possible end of life, that is the goal of the system. Some of those patients may elect at the end to use physician aid in dying. And I think that's what you've heard coming out of this as far as a system response.
All right, sir, thank you.
Yes.
So Helene Starks, and I'm one of the few people that's studying this at the level of implementation for whatever moral status that brings. But I think it's important to study the implementation. When I talk about this not just being the tail wagging the dog, but the last vertebra on the tail wagging the dog in terms of the population. But what I see, especially now in California, where I can look at it through a legal lens, which is very different from everything in the closet when it was illegal in Washington for the first round, is the ways in which this demonstrates how the system is really broken. And all of the things that have been discussed about shortcomings in the system are made clear when you're getting a group of individuals who are highly motivated, who are highly privileged, who are highly resourced, up against a system that really isn't working. So I beg upon us to be thinking about this way, as it is a canary in a coal mine about this system, and that we shouldn't be discussing any of these options in isolation, because it's not special. It is what happens when everything else up until that moment doesn't work very well. And I think that Joanne's points are extraordinary. And I think the deliberation is a really important piece, but the real question is, how do we talk about this as a case within a much larger issue, and let that be the driver? I think when we look at what advances in palliative care have happened, in many ways it's because systems have embraced the challenge of the ways in which they're broken. The one final thing I'll say is, we have to not just have those town halls once. It's time a year later to have them all over again, because there's a whole lot of people who got the memo and then lost the memo. So it is an active, iterative, deliberative, discussive process.
Before you respond to that, let's get Kim on very briefly, and then we'll see any responses both.
In the taxi with her giving me the look.
Okay. No, I apologize. We should have stopped, but we got some long questions there.
So really quickly, I just wanted to offer some perspective that might help in narrowing the research questions down. There was quite a bit of discussion about the Canadian system and, the Dutch system, various different things from just so that people are aware. The intention, at least for CNC and from everything I can tell of the movement, is not to try to expand this law to follow any of those other models. So we advocate for the Oregon-style model, all, and there is not any intention for that to get expanded. So I thought that might be helpful as you're looking at research questions.
Any last comments? People have to run. Thanks, everyone. Appreciate it. Thanks for coming to me and the comments.